1, 2, 3. Can you hear me? There we go. Take your seat. Welcome back. How's it going? Wow. Great to see the energy. Well, as we have our last session before lunch, and there'll be some great networking opportunities that I'll share with you right before lunch. My name's Keith Frey. I'm a member of the leadership team for the collaborative. And thank you this morning for joining us for an important conversation around the role of AI and clinician well-being. We kind of subtitle it, is it a hope or a hoax, or maybe a little combination of both? You know, we started to plan this meeting back earlier this year, and the planning group's buzz was, AI is a disruptor in our industry, and we've got to put something together to address that and what effect it may or may not have on the well-being of our workforce. And so as we kind of thought about that, we thought, boy, why don't we assemble a group of thought leaders who touch this space from various viewpoints and get their insights. Now, this is a broad area, as you know. I mean, there's a lot of voices in this and some different ways that we define AI. I personally like augmented intelligence when we think about it inside of the healthcare sector, but artificial intelligence is obviously what the public tends to think about. So I thought, because this could be so broad, what we try to do is anchor it around a recent report, which is entitled the 2025 Future Health Index that Philips Corporation published earlier this year. Now, that particular report, toward the end of the panel discussion, I'll have a QR code up, and if you'd like to download the free full report, you're certainly welcome to do that. But to get us all sort of centered on the same page, what I thought we would start with is a 7.5-minute clip from one of the co-authors of this report, Dr. Shez Bartovi. Shez Bartovi, some of you may recognize that name, started his career as a very effective neuroradiologist and informatician at Barrow Neurologic Center, and he's been a friend and a colleague for some 20 years. About 5 years ago, he went into industry and is the Chief Innovation Officer for Philips worldwide, and in fact, he and his wife live in Amsterdam. So this interview, just after this report was released, is him being interviewed on the floor of the New York Stock Exchange. And I thought it'd be a nice way to kind of get us all thinking about this topic before I pitch to our panelists some thematic questions that are around this. So we'll see if we can get the technology to work, and we'll go ahead and play it now.
Philips, a health technology company, just released its annual survey looking at the state of the space from the perspective of both physicians and patients. Joining me now with more on the results and solutions is Philips Chief Innovation Officer, Shez Bartovi. Shez, welcome.
Thanks for having me.
It's great to have you here at the New York Stock Exchange. And with this report just out, what are the key takeaways?
Well, this is the 10th year that Philips has done the Future Health Index. And this year we surveyed 1,900 clinicians and 16,000 patients across 16 different countries. So an impressive data set. And what was one of the most sobering things that came out of this is if you look at the voice of the patients, 3 out of every 4 patients said that they wait over 2 months to get specialized care. And if that wasn't alarming enough, 1 in 3 patients said that while they're waiting, they end up going to the hospital. Now, if you turn and look at the voice of the clinician, that was interesting as well. So clinicians said, look, despite advances in technology, that when I compare my work to 5 years ago, I'm still spending half my time doing administrative work. And a third of them actually said, I'm spending more time doing administrative work than 5 years ago. So this is actually quite worrisome, because with all the advances that we've had over the past 5 years, our goal was to actually reduce the burden on clinicians. So it seems that the industry, we still are overburdening them with administrative work.
How can technological advancements like artificial intelligence improve the health and well-being of patients?
Well, this is where AI has an incredible opportunity. And when you look at the survey, there was incredible optimism in the clinicians. So about 85% said, look, AI can automate things that I shouldn't be doing. That administrative tasks, they want AI to just automatically make it go away. And so if that is done, the survey said, look, I'll have more time with patients, procedures can be faster, I can have more face-to-face time and give back to giving what patients and physicians want, which is this interaction directly. The other thing that came through was about 82% of the clinicians said, we believe that AI can help predict conditions and help avoid them. And this idea of predicting conditions means that you can avoid hospitalizations, improve care delivery, and they said that we believe AI can help increase the accuracy. So when you put that together, clinicians believe that AI can help deliver better care for more people, which is an encouraging part given the headwinds that we've also seen in the survey.
How is Philips using AI?
So Philips has been leveraging AI for quite some time, and I'll give you an example of the automation that we've been doing that actually aligns with what physicians said they want. So if you go and have an ultrasound of your heart, the sonographer will spend 20 minutes scanning your heart, and then they look on the scanning machine and they try to find the best images of the heart, and then they go ahead and try to measure, they do little clicks and measure all the different parts of the heart. It takes 20 minutes, and then they get a number of how the heart stress is doing. So 20 minutes of scanning and 20 minutes of clicking. So Philips, for example, in our Epic Elite ultrasound machine, there's an AI software that with one click automatically finds the best image, does all the outlining of the heart, does all the measurement, and gives the number that's needed. And so this means you can have either shorter exam, you can have more face-to-face time, you reduce wait time backlog because your exam's gone from 40 minutes to 20 minutes. And this is an example of automation that helps deliver better care for more people.
I want to talk about the trust gap. I'm not sure if AI plays into that, but what are you finding when it comes to the trust between physicians and, of course, patients?
The Future Health Index had some really interesting data on the trust gap. So when you ask clinicians about if they are optimistic about AI, 80% said they are. In fact, if you see the survey in many places, they're very optimistic. You ask the same question from patients, and only about 60% were optimistic. So there's about a 20% trust gap. And when you sort of dive into it a bit more, you see the little subtle nuances there. So patients said, look, I trust AI for things like scheduling, for check-ins, where sort of operational work. But if you want to make a diagnosis and you want to treat me, I want a physician in the loop. In fact, the trust gap reduced when they said, if the decision is informed by a clinician, then I trust it more. So physicians and nurses, 80% trust, patients 60%. But if the patients, if you add a clinician in the loop, their trust came back up to 80%. So clear signal from patients that there's some things I'm okay with, scheduling, that sort of thing. But if it's about my care, AI should be informed by a clinician in how you treat me. Very, very specific.
Very interesting. What will it take to advance the adoption of AI to help with critical healthcare matters?
Yeah. So first and foremost, keep humans in the loop. I mean, the patients have spoken, right? The patients have spoken, which is why in the document we call on having human-centered collaboration between AI and humans so that the trust gap can be reduced. That's one area that will increase adoption and increase the trust. There is another area that 3 out of every 4 clinicians said, look, there is unclarity around regulations and liability, and you have to help clarify that for us. And so, which is why another part of the document, we called for not only maintaining the pace of innovation, but the regulatory bodies need to bring greater clarity so that it can be clear on how we can bring this innovation to patients. So those things will increase the speed of adoption.
We've spoken a lot about artificial intelligence. What are other trends or innovations that you think will shape this industry over the next few years?
This is a great time to be in healthcare. Look, with the advent of generative AI, we have entered the age of intelligence. Society's gone through the industrial revolution, the digital revolution. We are now in the midst of an intelligence revolution. And what that really means is that it's the first time that you can have reasoning, you can have understanding. And so as an industry, health tech, med tech, we have an opportunity to add that kind of technology so that the equipment and the software that we build isn't simply displaying data, but actually is providing additional insights. For example, we're going to be at a point where an MR scanner doesn't just scan the patient, but actually says the Alzheimer's is getting better. The CT scanner doesn't just scan the patient, but actually activates the stroke protocol and reserves the ICU bed and notify staffing for nursing that there's a stroke patient coming. These kinds of things are automations that are going to happen as the trends with generative AI coming in. It's a great time to actually have a positive impact on healthcare. If you want to make a positive difference, this is the time. And Philips wants to deliver better care for more people. We are thrilled to be here.
Shez, thank you so much for joining me. Such an insightful conversation here at the New York Stock Exchange.
Thanks for having me. It was a delight.
In person, he really is that enthusiastic. So he's a great guy. And I hope that helped get us sort of framed. Let me introduce our panel now. Both Dr. Trockel and Dr. Pipe have been introduced, and you've had an opportunity to hear them. So I'll move over to Dr. Jackson. Dr. Jackson is currently working at the Mayo Clinic as the Director of Partner Enablement at the Mayo Clinic here in Arizona. He comes into Mayo Clinic with a huge industry experience, startups, tech startups, investor. So we really got somebody who sort of lived in with a foot in both camps. And then Dr. Heather Carter is with us today. Dr. Carter is the CEO of Health Choice and the General Manager for the Medicaid plan at Blue Cross Blue Shield of Arizona. May be familiar to many of us here in Arizona, having spent a distinguished career in our legislature. So somebody who has been on the regulatory and the governmental side now has stepped into the industry side. So we have a great panel today. And you know, Shez touched upon in this report, really, there's 4 thematic areas that the full report, if you want to download it here in a little while and read it with some more depth, I'm going to sort of be pitching questions based on their background and their expertise, and then ask each of them, if they will, to sort of add additional insights as we go along. So those 4 themes, if you didn't catch it during that short video clip, include how AI might help relieve the strain on healthcare systems. What will it take to build trust in AI between patients and clinicians was the second theme. The third was around that ethical and regulatory guardrails that are needed to sort of protect the adoption pathway. And then finally, how could AI reshape the future of the delivery of healthcare itself? So those are the thematic areas that I've built a few questions around so we can mine the great minds that are up here today. So Heather, I'm gonna go to you first, even though you're furthest away, and I'm gonna take, if it's okay, the moderator's discretion, because we all have doctoral degrees, and this is a conversation. Would it be okay to call you by your first names?
Always.
Okay.
Always.
All right, very good. Well, Heather, again, given your background and your current role, how can AI realistically reduce patient backlogs without creating inequities in access? And particularly as you're managing a large Medicaid program, inequities is something we're always trying to be mindful of. Love your thoughts about that.
Nothing like getting the hardest question right out of the bat, right out of the gate. You don't hold anything back here. Well, first of all, thanks for organizing this today. I think it's a really exciting time to be coming together with so much uncertainty in the healthcare delivery space, to be able to bring together practitioners, thought leaders, industry experts, nonprofits, and just the unified stakeholder group we have here today. This is a really important conversation. So as it relates to AI, obviously, I'm bringing 2 perspectives to this conversation today. One is as the CEO of a Medicaid plan, and the second as the former lawmaker that used to have to wrestle with state statutes around regulating the industry. And I'm probably not going to give you an answer here that you're going to love, but the challenge for me right now as the CEO of a Medicaid plan is getting a clear answer on what is and isn't allowed in order to figure out how we can best utilize AI to help support the members that we serve for the state of Arizona. And what's really interesting is that as a Medicaid plan, we are actually contracted by the state to deploy the Medicaid system to our members. So when you're talking about the use of AI in a commercial space, it's actually different than in a regulated space like a Medicaid plan. And the challenges that we face every single day AI is coming so fast down the pipeline, affecting every single piece of the work we do. And if it's not affecting the piece of the work that we do, it's affecting the piece of the work that our providers are experiencing, that our members are experiencing, that it is really challenging to just take a breath. I'll borrow from, Dr. Pipe here, that, to take a breath and say, is this allowed? How does this help? And does it help meet our goals? You brought up the issue of health equity. At the end of the day, a big part of our work is figuring out how to deliver on the state's health outcome goals, which are tied in all of this equity work. And so AI has this incredible potential, even just down to analyzing data to help us make decisions. But then on the day-to-day front end of how we partner with our network, how we partner with different systems, and yet I don't have the clear answers that I need, to get over the hump to figure out what we can and cannot do. Every day I ask a question, is this allowed or is that allowed? And sometimes I get different answers. So sometimes we just don't move forward because we don't know whether it's allowed. But remember, that's in a Medicaid space. It's really going to depend on what happens federally. Does the federal government come in and preempt this? There was lots of conversations around that. But right now, it's regulated state by state by state by state, and we're actually doing the work of the state. So we have even an extra lens of analysis that we have to do as it comes to using AI. At the end of the day, I think there's tremendous potential if we could just get a straight, clear answer on what we can and cannot do.
That's great. Thanks. Yeah, that was a little bit of a difficult question. We'll come
How'd I
back
do?
to-
Did I do okay?
That's right. Well, I think we're all warmed up here. Well, we're going to come back into the clinician-patient relationship. And Teri, I'd like your thoughts maybe to start us off on this next domain. What balance should be struck between improving efficiency, thinking in terms of the delivery system, and maintaining that human touch in care? And so from your lens as a career nurse, how do you see that being balanced?
That is also just that is a great question. So in terms of healing, that connection is preeminent. And I believe that for not only the patient, but for the clinician as well, is that connection and the ability to have compassionate care is at the heart of what we do. And so will AI impact that? In some ways, it is very promising that having even things like ambient note-taking, so meaning that in the air of the exam room or the hospital setting, there are sensors that can understand the auditory nature of signals and can chart during the encounter. That's amazing and great, and could really save clinician time to be more focused in the moment with patients. However, for some patients, they come to those encounters with vulnerabilities and perhaps not a knowledge that they're being recorded, and they may share things that they wouldn't otherwise if they knew that they were being, that their sounds were being recorded. So I think where all of this lands is in the frame of ethics, and having ethics be at the forefront of, how do we talk about this, and how do we really understand the nature of that relationship in terms of the technology. And then also just one other thing is that in reading this report, a word that I didn't see two words that are really important to me, and one is ethics and the other is compassion. Mm-hmm. And so how do we understand AI in terms of intelligence? What is human intelligence? What is artificial intelligence? Where is there overlap? Where is there, when does artificial intelligence blur the lines between what consciousness is and awareness?
That's great, Teri. Thank you. Yeah, so we see opportunity in that trust gap that Shez referred to, and yet some peril if we don't figure out some of the guardrails. Mickey, we were talking earlier this morning, and I was reminded listening to your talk about the importance and the mitigation of burnout with teaming. Teri was talking in terms of the clinician-patient, but talk a little bit about where you see maybe AI as a potential risk with teams.
Certainly. And we can see this in what's happened already with implementation of electronic health record and other technologies. imaging technologies, making it less necessary sometimes for members of the healthcare team to talk to each other, other than by email or Slack or other electronic communication, text, which just isn't the same. A powerful story that some of you may have heard if you've been to our Chief Wellness Officer course or heard David Larson from Stanford speak, is an example of a wellness intervention to mitigate this for radiologists. And what he simply had people do is to make sure that the radiologist was the one who gets to deliver the news for oncology patients when it was good, so that they'd come up from their somewhat isolated office and be the one to introduce themselves. Hi, I'm Dr. So-and-so, and just wanted to let you know I'm the radiologist. I read your imaging, and you're in remission. And that made such a difference that they were part of the team, they were interacting. And so as we think about AI tools, scribing, automation in getting messages from a CT scanner that lets the nursing office know that a patient's coming. You can think about how many steps that removes a conversation between people. And so how are we going to mitigate that? How are we going to keep people connected as we do our work in a world that implements fast-paced AI changes?
That's great. Great example. Well, Jerrold, I have something for you. How can we bridge the trust gap between patients and clinicians when it comes to AI adoption? And you've been a clinician, and you've been in industry, and now you're kind of back in a big health system. So as you sort of see this, what do you see from your lens around the trust piece?
Sure. So I'll begin actually taking a page out of Teri's book, Gratitude for being here. Thanks to, I think, Keith Jones, was maybe the first offender, combined with Dr. Cynthia Stonington. That's how I met Dr. Frey and Flo. So thank you for that and for being here. To preempt the answer to that question, or some thoughts on that question, I'll just paint a slightly wider picture about my role and kind of the space I exist in. So spent about 10 years as an LCSW psychotherapist in New York City at Mount Sinai Medical Center. Then went on to do my PhD at Mount Sinai School of Medicine, more of a research-focused clinical translational research, and then last 15 years or so in industry. So I've started companies, and I've been on the investment side of companies. And now at Mayo has an AI-specific business unit called Mayo Clinic Platform. And while I am based here in Arizona, in Scottsdale, my work is global. So I meet, and the team I lead, meet companies every single day all over the world who are building AI and attempting to use AI to solve solutions, like the ones that we're talking about. And what's interesting is I think that the technology itself and the thoughts and implementation of the technology are way out ahead of the patient. Way out ahead of the patient. We have not pulled the patient all the way through. We talk about humans being in the loop. Stanford, of course, led the way in authoring a lot of that. I've co-authored, along with my wife, who is also at Mayo, Dr. Melissa Pinto, thoughts on a human near the loop when a human in the loop is not always possible. But the patient human, we don't always keep in the loop all the way through. And so to even riff on some themes that we've talked about before, in addition to ambient scribe, we even have solutions that will analyze the tone of your voice while your voice is being scribed, and then make certain assumptions about your mental health. And do we even let you know that we're doing that? Right? It's interesting technology. So as a technologist, I love the idea of that, where you can go in for a primary care visit, and we can also perhaps do some access 1, access 2, early diagnoses, maybe even some rule outs. But the ethics of that are not nearly where the technology and the highly available compute and the desire to bring automation into the point of care is. So I think we've got a lot of thought to do, maybe to catch one up with the other.
That's great. Well, the following question was just to follow on is that the whole issue of transparency. It's informed consent. And you brought in not only for the patient, the customer, but the informed consent for, the employee, the clinician, whatever that is. What's your thinking just about that level of transparency?
So a couple thoughts on that. Informed consent, when you've got the solution built and packaged and you're there's a real patient that the algorithm is being run against, that's one thing. How about informed consent for the use of the data's patient to train the algorithm in the first place? Right? So there's a lot of thought there. There's a lot of work around de-identification of data and ethical use of data, but I do think there's quite a bit of work to do to pull the patient all the way through. I won't ask anyone to raise their hands, are there any patients in here? Because the irony is that we're all patients, right? But did we deliberately invite anyone from the patient perspective, for example, right? And so I go to lots of conferences, as I'm sure we all do, and do these kinds of engagements, and I'm grateful to do it. And it's rare that we have the patient at the center of the conversation.
Yes, excellent. Why don't we just sit on that for a minute and just talk a little bit. Any other thoughts or comments about Jerrold's thoughts about the transparency piece? We can move on to something else, but I just wanted to make sure. Okay, from the nonverbal, we're going to move on. So back to you, Mickey. Patients overwhelmingly trust clinicians for guidance on AI, as we saw. How do we ensure clinicians themselves feel prepared and supported to take on that role? So I'm kind of thinking about it from a leadership development, training the next generation of doctors and nurses. What's some thoughts that you have sitting at Stanford as a faculty?
And thinking about what Teri said, as she was describing some of the differences, beginning to describe some of the differences between artificial intelligence and human consciousness. And for those of you who are old enough, like I am, to have watched Star Trek, you remember Data. So this has been an idea in mind for a long time. Now, what did Data miss? Data was an artificial humanoid, and Data didn't feel. And that's really an important concept. Because if artificial intelligence doesn't feel, then that completely negates some of the most important aspects of the art of medicine. How can we think about compassion without feeling? The definition is feeling the suffering of others and wanting to mitigate that suffering. So that's just a game changer. And so being able to teach people to think about in a very purposeful and systematic way where the limitations of artificial intelligence are and where human interaction is needed, and to give everybody a level of confidence that we are approaching that systematically so that the art of medicine is not going to be outsourced to somebody else. And so those of us that are engaged in patient care don't have to worry about that. And that includes the decision-making piece. I mean, some of the concepts about the importance of establishing trust relates to regulatory answers on what we are allowed to do with it. And one of those regulatory answers is who's responsible for following the direction of AI. So one is if AI makes a recommendation and it goes badly, then who's responsible for that? But think about the reverse. As it really advances and becomes phenomenally effective at diagnosing and indicating the best treatments, then will healthcare workers be liable for not doing what AI suggests? And that's a really scary concept, especially when we think about the limitations of artificial intelligence, because what we feel and the intuition that comes from that in the art of medicine really matters.
That's so good. That's that, as the technology advances, we want to keep the humanness, the humanity in medicine. It is we're not in a tech industry, right? We're in a service industry. And the interactions are in an exam room, an operating room, at the bedside, and want to make sure we keep that. And I love that radiology example. I mean, there's that and pathology are among the highest uses right now of AI, and pulling them intentionally back into the patient interaction is maybe one of the ways as leaders we can be thinking about that. I love it. Thank you. Teri, just to kind of build on this, so what strategies do you think we can reassure patients that AI will not reduce the face-to-face care? Just kind of picking up on this theme. And as you're thinking, again, I was mindful while you were speaking today about the freshmen, and some of those are, stem cells that become clinicians at some point down their plural potential pathway. I mean, what do you see as sort of ways that we can kind of, keep the humanity in the center?
So I think that's the ultimate question, isn't it? I mean, how do we march forward? And AI will march forward and will continue to. In the field of nursing, I just saw this week that the National League for Nursing just released recommendations for how to address AI from a nursing education standpoint, because we need to do faculty development. We're behind. We don't have the competency and the confidence that we need to move forward. There's also just a great opportunity here to engage AI actually in the educational process, and I can give you an example in a second if you're interested. But then also just thinking in terms of not only regulatory and faculty development, but also preparing new generations of clinicians with the skills and competencies of AI, along with the relational skills and the ability to be in a room and notice, what are you not seeing? To listen for what's not being said here. Or even things like, as a clinician, do you remember the first time you smelled gangrene? Right? And so how do we honor the role of the human instrument as clinicians? And I would also bridge that for leaders. We also need to think about how we use AI to really be robust leaders, but also to not replace the humanity in our leadership roles. I'm not sure that I had addressed your question.
Did you, that example, was that example?
Sure. So the example is how a colleague of mine used AI in an assignment. So she teaches public health, and what she did is I don't know if you've noticed, but in public health these days, there's a lot of controversy. And so she had the students choose one issue in public health that they felt very passionate about and argue with AI. They had to do a 3-round debate using AI as their respondent, and again, go 3 rounds and try to convince AI of their position in a very polarized, whatever they chose had to be very polarizing. And what the students came back with was their observation that doing that was really helpful because AI has no emotion. And so it wasn't like our Thanksgiving dinners where we're engaging in, high emotion debate. It was no emotion debate. And so it allowed the students to sort of hone in on their argument. And then one creative student asked AI, had the student convinced AI of their position or not? And the jury's out on that. But I thought that was creative.
Yeah, very, very, very good. Excellent. Let's kind of come, we've kind of been talking a little bit about the role of regulation and governmental oversight. Heather, I want to kind of draw you back in here, given your career. What governance structures are needed to continuously monitor both bias and fairness in some of these tools we've been talking about? And again, broadly, we don't want to over-regulate, we don't want to under-regulate, so it's just, again, your perspective and your career of being on several sides of this. Thoughts?
I think I'm getting the most difficult questions. That's my thought. So thinking about this reminds me back when I was first running for office, and the year was, I started serving in 2011, and I was the vice chair of the House Health Committee, and Representative Cecil Ash was the chair. He wasn't as passionate about healthcare as I was. He was actually more passionate about criminal justice reform. So he would leave the health committee and leave me to chair the health committee as a freshman. And we were having a very, very robust debate about electronic medical records. We haven't even finished that debate. No. And what I see happening is that the world and the innovators and the systems are advancing light years ahead of the regulatory environment, to where it is near impossible to statutorily even define what we are talking about when it comes to AI. Don't remember what was mentioned here, but is it, and then what do you do with it? Once you have it statutorily defined, how do you use it? we're still trying to define, in many cases, electronic medical records. I will ask for a show of hands. How many of you have seen when your patients come in that they have to basically opt into electronic medical records? Like you have to ask them, like, we're going to keep your electronic, do you know what I'm talking about? I see one hand. Well, you all have to. Bayo does it. You all have to. This is a debate at the absolute, like, minutia level of passing legislation. So what happened, I just took the job in June, and in July and August, there was the Arizona Department of Administration was starting to update their policies around AI and what is allowed and what isn't allowed, and they have to do it within a regulatory framework of what's allowed by statute, and so this is the policy work. And basically, it is so nebulous that they haven't even defined like what AI is or isn't. So you have this whole regulatory environment that you have to deal with from federal, state, your policies and procedures. And then what's happening is AI is showing up in places where you least expect it. So probably the simplest example of AI that I would see more as just a patient myself is you go into the doctor's office and the doctor says, do you mind if I record this conversation for better charting? So in my mind, and I have a doctorate degree, I'm thinking that they're just using this information to chart. Now, what you've already heard here in today, they might be listening to my tone, my tenor, everything else. That's not in that little word that you say really, really, really quick to the patient. Do you mind if I just record this conversation to chart better? So you asked a question about trust a minute ago, and that's why I'm bringing this back to that conversation about trust. We don't even know where this is going yet until we see the unintended consequences on the other side. For example, what's happening, now once again, I am just repeating what I've seen on news and in social media, which is very, very dangerous. So I'm giving you my bias right off the bat. But you're now starting to see AI make mistakes. You see hallucinations. You see them giving advice that wouldn't be aligned with what a practitioner would give if you had that human element there. We haven't even begun to think about how to regulate that sort of activity. I mean, we're seeing in the health insurance space things showing up in the chart and things showing up in coding that when we go back and we do the human audit of, did this really happen in the room? Sometimes things are showing up in the chart that didn't really happen in the room, or things that would typically be in a chart like way down at the end, and maybe that's not what you're billing for because they came in for a respiratory infection, but next thing you know, now you've talked about sepsis somewhere, and now sepsis has moved to the top of the chart. We're seeing unbelievable examples of how this is also affecting, the way it manifests throughout the entire system. And it affects the patients, it affects the provider, it affects the payer. And at the end of the day, I don't think anybody thought that that's where we would be with AI. So I wanted to wrap that all up together. We can't even figure out how to statutorily or procedurally or through a policy define it.
Yeah.
And until we can do that, we can't really even regulate it.
Yeah.
And then we're having all these trust issues of what's really happening with the data.
Yeah, well, that's so well said. We're still on a journey with electronic medical records. I mean, but it was 10 or 12 years ago, we were dealing with the cut and paste forward issue, both in the hospital, just expedience. I'm just going to making rounds, going to cut and paste things forward, and then things are being brought forward that are no longer relevant, and the errors that come out of that.
And we're still faxing records. Can we all just vote? Can we all just come together and everybody go to the top of the building today and if we all at one particular time throw the fax machines out the window at the same time?
Thanks.
That might help us.
So maybe
Sorry,
we'll have a table on the anti-fax movement. Jerrold, let's kind of thematically stay in the regulatory space as somebody who's been sort of out in the industry developing and now sort of in a more regulated environment. I'd just love your perspective, build on Heather's comments.
Sure. So two frames on this. One is it's often said that some countries will innovate, some countries will imitate, and then other countries will regulate. And I think the sweet spot somewhere is probably in between all three of those, some Venn diagram where we balance getting out ahead and not restraining high compute, transformer models, et cetera. We learn from other countries, right, what they're doing, but also we put some guardrails on. And there are both domestic and international groups who are kind of doing all of that. Another frame I'd put on this is the role of AI agents. So whether they are pushed all the way to the edge in sort of humanoid form, or who in this room works either on the provider side or the payer side in prior auth? I see no hands. I saw one. Okay, two hands.
They may not feel safe.
I was going to say you're out there. You're out there. So here's what you're seeing in your industry. There are AI startups and more mature companies alike who, on the provider side, are saying, let's automate this, right? So we'll crawl the record and maybe even put an AI agent on the end of it to actually prompt a reach out to a payer to try to get something authorized. On the payer side, we're seeing the same thing. We're seeing AI enablement around an AI agent that picks up the phone or answers the message. And it's interesting because in other industries, we've seen both AI agents and then adversarial agents who are trying to battle. And we're seeing this happen in one or both sides as well. So forget even prior auth. If you call into, any company, any industry right now, you may or may not be talking to an actual human. But then imagine if we have agents working on both sides and what implications that has. So as we think about innovate, imitate, and regulate, somewhere in between those, on one hand, if I work in prior auth, okay, it's fine. I'd love to sort of shift to things that maybe I'm operating at the top of my license every day, but I also am not super cool with an idea of an agent on the other side of my agent, right? So I think as we evolve, just kind of that framework of innovate, imitate, regulate.
That's good.
We probably end up somewhere on some Venn diagram between those three.
And I'm going to add on to that, like there is if there was ever clarity in anything around AI, it is really that when you're in the denial space, it has to be human. Like there's no, you may do some processing around, but when it gets to like the final no, you can't go forward, that must be done by a human. Like that's the clearest answer I can get on almost any, like that's the space I'm like, I got that answer. I know that one. It's the rest of the stuff that's a little nebulous. But right around prior auth, it must be touched by a human, and a human that is in the appropriate regulatory space. They have the appropriate license, experience, and knowledge to make those decisions. So that is like, you do not pass go on that.
I love it. Well, we're gonna transition to sort of my final question. I'd like each of the four of you to address, and we've kind of looked at kind of current situation and some of the concerns and limitations. That's good. But I'd like to kind of have you be thinking more forward and dreaming a little bit about the future of where this could go. So let me frame the question this way. And, as you're ready, why don't you share your thoughts? How can AI shift from being a back office efficiency tool to drive better health outcomes in health? So 10 years from now, what would you see as healthier Arizonans as a result of where AI could be going, assuming we get all these other things fixed? So I'm going to ask each of you to comment, but whoever's ever ready to jump in first, please do. The future, Teri.
Do you mind if I do? So this is going to be in a realm that might surprise you because it's around energy usage. So AI uses an incredible amount of electricity and other resources. So my ideal, so that's sort of the problem area, but my ideal, and I'm drawing this from a report I read out of Penn State recently, is that AI would become more streamlined and perhaps more sector specific. So in terms of like healthcare would be one sector, business might be another. And so the more that we can get those sectors aligned, the less energy usage will be had. I'm not an expert at this, but here's how I understand it, is that right now all the language modeling is across sectors. So a lot of energy is being used. It's actually wasted. It's wasted time and energy. So getting the technology to be really thoughtful around resource usage and helping us as users and consumers of it to know when to use it and when it's really not necessary, when we don't need to tap into it.
I love that. It's a very holistic look at it. Great. All right, other thoughts on the future and the hopes and how this can help drive better outcomes?
I'll go. I'm thinking about a specific example, and it's in integration of what we're already seeing in programs like Open Evidence. How many of you have seen that? Have anybody played with Open Evidence? So I'm seeing in the future where that's much more sophisticated and helps physicians and their patients with shared decision making. I'm thinking about a specific gap that could be bridged with this this achievement. I'll share the example of my brother. He has a PhD in applied mathematics, so he's good at looking at the math for evidence. And he has 3 problems, all of which don't have great medical solutions. One is some osteoarthritis in his hip, which irritates him because he's an endurance athlete. And he has a Dupuytren's contracture, which is a contracture in some of the tendinous structures in the hand that start eroding flexibility. Not too bad yet. Both of these are fairly mild at this stage. And he has some degenerative disc disease. And no medicine is in any robust evidence way demonstrating real efficacy for any of those, much less all 3. And yet, he's able to evaluate evidence and see with emerging clinical trials, some phase 2 trials already published, populations that don't quite match his, that metformin is very likely to improve all 3 of those conditions. Now, if he on his own takes his reams of articles and goes to his primary care doctor and says, I want metformin, here's why, that automatically is going to put his primary care doctor on the defensive. And it may or may not go well, depending on who it is. On the other hand, if an evidence-based program could evaluate not just strength of evidence, but likelihood of side effects, with metformin has some, but one of which is probably longevity. So, thinking about risk in complicated ways and patient values and all these things, and helping the physician and the patient make shared decisions, particularly with things like off-label prescriptions. That would be really nice. Get everybody in. Plus, then people that don't have an applied math degree could get the same benefit.
Wow, that's great.
That leads right into what I was going to say.
Well, perfect.
And I'm going to take it like way down to the individual level. Democratizing health literacy. The gatekeeper for your health is no longer going to be the healthcare delivery system, the insurance company, the provider et al. When you're able to access that kind of information, and obviously everybody's going to interact with AI at whatever level they're comfortable interacting with AI, but this next generation of individuals that are in school right now, the interesting thing is, all signs on social media point that they are unplugging, like from social media and the daily grind of that, but they are absolutely plugging into AI to the point where they almost can't do anything, even way down in the elementary school levels, without somehow figuring out how to use AI. And if the kids aren't using the AI, the parents are using AIs to answer the new math questions. So they're learning like how to use AI to solve their problems. So you're going to see patients showing up in your office and in your systems and being part of your health plans that have access to more information than they've ever had in the history of healthcare. And so how are we going to respond to that as payers, as providers, as educators out in the community, because there's no gatekeeper to the information. And if you think about it, once again, I'll take you back in history. Do you remember when they first started doing all the advertising for pharmaceuticals on TV and how the backlash was like, now you have patients coming in saying, I want Jerry. I mean, we can all sing and dance all of the commercials. They're very flashy. But now you're going to have patients coming with what you just explained in. Like, this is a game changer for the system. If there was ever a disruptor, that there's no regulation on the patient side. Like, the patients can do whatever they want. So we're talking about how we react on the system side. There's no regulations other than what they have access to and what they don't have access to. So it's going to be just an absolute, I think, complete, I don't want to say free for all, but I don't know what the positive spin on that would be. Opportunity for people to take more ownership in their own healthcare. And all you need is a phone. All you need is a phone. And so I think that's just going to be a game changer that we haven't even started to look at.
You see kind of a yellow flashing light.
Yes, like the.
Yeah, right. Just on.
If you have any questions, find the yellow flashing lights.
Well, Jerrold, why don't you take us home and maybe balance that with a more optimistic perspective?
I'm very optimistic about that. I don't know how we're going to handle it, but I'm optimistic for the people. I'm optimistic for...
Yes. Yeah, the democratization.
Right. I'm optimistic for the people. I'm not sure I have confidence in the system to be able to respond to what the people are going to drive.
Well said. Well said. Thank you.
Certainly. Happy to try to wrap it up. I'll actually start by saying I was going to not mention any specific names of companies, but Open Evidence worked with Mayo Clinic Platform years ago to train some of their early models. So that's one that that is near and dear to Mayo Clinic and to Mayo Clinic Platform. I should also say, as I round out my comments at least, find me afterwards. I think maybe any of us, I should say, a lot of things were said on stage which probably provoke other questions. I talk for a living, so happy to talk with any of you all, either in person or after this. So a couple of, yes, positive spins, wrap it up, optimism. I've raised some things that I'm concerned about, but I'll tell you what I'm also encouraged by. There are some solutions, and I can mention them off the stage, off a mic, to seem less biased, but that are empowering patients on their way into visits. So imagine, all of us, I don't even show your hands, but none of us, I should say, enjoy the pre-visit in the waiting room, paper and pen thing that you have to fill out, or even worse, they send you the email a few days in advance and you ignore it and get there and they say, did you do it? You say no. There are a couple of companies that are actually working on making that really, really simple. So you simply talk to your phone. It's a conversation. And it segments different aspects of what you say into the beginning of a SOAP note. So your provider, by the time you're in their chair, has a bit more information about you, combined perhaps with what they already had with you, let's say through, Epic Care Everywhere, which is, once again, love it or hate it, but things like that pull in your prior records before you actually have a seat in your provider's office, in which case your provider can spend more time with you talking human to human versus reading your chart and kind of having an awkward, looking at you, looking at the chart, looking at you, looking at the chart. There are a host, once again, won't list any right now, but a host of SDOH focused AI innovations that Mayo Clinic Platform and others are enabling on both the provider side and the payer side. And so we're seeing some companies wanting to leverage the idiosyncrasies of all of us from a social determinants of health perspective to optimize care, but also help find either efficiencies or savings. So there are a number of these solutions that we are seeing, despite the big scary caution, but still proceed message that you may have heard, certainly from me. There are many reasons to be hopeful, and I'm super excited to revisit those with anyone afterwards.
Thank you. Thank you, panelists. I mentioned, again, the full report, if you're interested, take a picture of the QR code. It's free, gives you a little, it's not, it's a piece that gets you thinking. And, in full disclosure, I took the report, fed it into ChatGPT, and asked for moderator questions. And that gave me a first generation set of questions that I curated this week. And sort of knowing you each, I pitched them this way. So even for an old guy, AI can be kind of a helpful tool. So, let's, before I give you instructions about lunch, can you show a round of applause for our panelists today? Thank you. Thank you very much.